Hello everyone. Today I have come up with a very new session about antibiotic guidelines in hepatic encephalopathy, like patients of decompensated liver disease, chronic liver disease coming with fever, infection. So we are suspecting spontaneous bacterial peritonitis. So we can see how we evaluate and initial management goes for adult patients with suspected spontaneous bacterial peritonitis. Okay. So today's topic is SBP. So patients having cirrhosis, they come up with ascites and suspected spontaneous bacterial peritonitis. So so when do we suspect spontaneous bacterial peritonitis? So patients are having ascites, cirrhosis related ascites. Okay, cirrhosis related ascites with abdominal pain, tenderness, altered mental status, fever, hypotension. So basically we are seeing the signs of infection. Okay, so when they come to us in ICU, we perform diagnostic paracentesis. Okay, diagnostic paracentesis we perform and get PMN count and culture. Okay, at the same time we take blood culture, urine culture also. So then we have a scoring system, Cliff SOFA score, and we see with that scoring system we check the severity of illness. So now we can see what is Cliff SOFA score. Okay, so it is chronic liver failure sequential organ failure assessment score. It has subscores ranging from 0 to 4. Okay, 0 to 4 subscores. So it has 6 components. So we can see which are the 6 components in it. We have bilirubin, creatinine, then hepatic encephalopathy grade, hepatic enceph grade, INR, vasoactive medication amount necessary to prevent hypotension, and also P/F ratio. So higher scores suggest there is severe organ impairment. Okay, that is Cliff SOFA score. So if you are getting Cliff SOFA score less than 7, we can go for empiric antibiotic therapy. Like we can go for third generation cephalosporins like cefotaxime 2 gram IV we can start with 8 hourly, or ceftriaxone also we can give 2 gram IV OD. Okay, so if the Cliff SOFA score is more than 7, that means there is, I told you, there can be severe organ dysfunction. So we can start carbapenems like meropenem, ertapenem. We usually go for meropenem and also imipenem. Okay, so by that time we start the empirical antibiotic therapy. By that time our PMN, ascitic fluid PMN count will come. Okay, ascitic fluid culture will come by that time. So from that we have to see whether the PMN count is more than or equal to 250 cells per microliter. Okay, if it is more than 250 cells per microliter, we can almost confirm that it is SBP, there is spontaneous bacterial peritonitis. So we already started the antibiotics, so we have to give albumin, supportive treatment with albumin 25% solution we have to start. Okay, 1.5 gram per kg we can start with once the diagnosis is established. Okay, so how do we give albumin? So I told you 1.5 gram per kg IV, maximum dose is 100 gram. Okay, so on day 3 we go for 1 gram per kg IV, again maximum dose is 100 gram if creat is more than 1, okay, and BUN is more than 30, or total bilirubin is more than 4 milligram per year. Okay, so that's about albumin. So we can use the ascitic fluid culture also. So PMN count we can see. We can go for ascitic fluid culture also. We have to see when any organism is getting flushed, and we can start antibiotic therapy according to that. Okay, so if the number of cells are less than 250 cells per microliter, okay, so we can discontinue the empiric antibiotics unless there is evidence of another infection, any secondary infection. So we can evaluate for other causes. Okay, so that's all about the management of SBP, evaluation and management of SBP basically. So there are many other factors also, there are many other things also we have to do in the ICU, depending upon what severity with which the patient is coming in. Like if the patient is coming in with fever, hypotension, and like breathlessness, drowsiness, it all depends upon the patient factor. So our initial management goes with ABC only. Like if the patient is unconscious, patient is drowsy, patient is breathless because of pleural effusion or something like that, we have to secure the airway. That is a primary choice. We have to prevent aspiration. We have to secure the airway component first. Then patient is having hypotension, we have to give fluids, we have to check the IVC, see for a 2D echo, see for a POCUS examination, see for the lung shadows, if there are any B lines or not, if there is any consolidation, if there is any sinusoidal sign for pleural effusion. Okay, see all that. And if the IVC is collapsing, the heart function is good, no diastolic dysfunction, LV function is fair, give little fluid boluses, and give little fluid bolus, and we can start fluid therapy also, titrating to the dynamic parameters that we see. And also a little bit of NORAD, depending upon the hypotension with which the patient is coming in. And again, we have to go for, and after the, apart from the antibiotic therapy, we have to check for the ammonia levels. We have to make sure that patient is passing adequate number of stools per day. We can start with a, Dufalac or lactulose. Rifaximin also can be started with, like 550 milligram BD can be given. So there are many other things that we have to do in SBP with DCLD patient. So I have given only details about the evaluation and management of SBP. So that's all it for today. Hope you have got some knowledge from it. So thank you so much. We'll come up with a very new video in the next session.